differing levels of maybe more reticence or vaccine hesitancy in certain, let's say, racialized communities and so on. Therefore, it's also very important to engage with community leaders in those communities. And we've seen them do that. For example, in various Indigenous communities, the leaders have come forward, they've gotten vaccinated, and they've actually put it on social media and so on and say, look at this, I got my vaccine, I'm protected, my family's protected, it's good for me, it's good for everyone. So those are the kind of things we're doing. And I would say at the end of the day also, I think there is a bit of a responsibility on every Canadian. You know, the fact is that the internet's a powerful tool. And there's a lot of misinformation and disinformation and so on and so forth. And so the responsible use of the internet in terms of not, say, using clickbait and, you know, making a sort of misinformation go viral, I think is also very important. And finally, I would say that,
Dr. I'm going to have to cut you off there.
Okay.
Dr. Quashtan, why was 4 months selected in the dosing interval for Pfizer? Why not 3 or why not 5?
Yeah.
Why 4?
Excellent question. So what the modeling had showed us is that the ideal interval would be 6 months if we wanted to have the most gain in terms of decrease in hospitalization and death for Canadians. However, when we looked at 6 months and the supplies that we were going to have, it was said to us that we would never need to go beyond 4 months because we would have enough doses to go there. So
4 months was chosen simply based on a vaccine delivery schedule.
Vaccine delivery and mathematical modeling.
Okay, so there was no actual scientific. This was purely based on a pure procurement schedule, like desperation in a pure procurement schedule.
Well, there's a basis of science, but you're right that, you know, why 4, not 4.5 or 5 was based on procurement.
Wow, that's I'm kind of shocked. Do you think that Canadians might be concerned that you're making decisions based on procurement schedules rather than solid clinical data?
Well, the thing is, we looked at a 6-month interval, but didn't think that we would need to go up to 6 months. I think that, and you can look in the literature, you have very renowned vaccinologists such as Stanley Plotkin in the US, who is recommending also to delay the second dose for as long as needed to give that first dose to as many people as possible. But
the Americans are going to be all vaccinated by May the 1st, so it's kind of
because they have, I know, but
they have supply, right?
They have supply.
We don't. So we're at the heart of this here. We are, to use the chief science officer's words, conducting a population-based experiment on a non-data driven dosing interval because we failed on procurement. Is that a correct characterization?
I can't tell you how procurement works. It's not my...
But we don't have the supply. And so we've been forced into this corner because we don't have the supply.
I think that given scarcity of vaccines, you have to make the best decision given what you have.
I'm sorry. It just blows my mind. And I know it's not your fault. I know. No. I get the situation you're in, and it must be hard.
I can't say it's easy. No.
Yeah. No, I understand. So on that, I think you and I share something, because I get calls in my office for people going, "What should I do? Should I take the AstraZeneca vaccine? Should my mom take the AstraZeneca vaccine?" Obviously, I can't say one way or the other. I have to rely on advice. But I've got you guys saying one thing, Ms. Elmsley saying everything's changing every day. And I feel like what that does is this lack of a protocol, this lack of supply is leading to confusion in the Canadian public. And it's really hard. So I'll go to perhaps Dr. New. Has the minister given you any direction to develop a better communication protocol, given the debacle on the conflicting advice and balkanization of provincial guidelines on dosing and availability?
Okay, thank you very much for the question. If I understand, no, the minister has not given me any personal direction in terms of communication. I think it's fairly clear.
Do you think it's necessary though? Like, do you think like this kind of seems like a bit of a cluster in the public? Like, do you think that perhaps a better communications protocol is needed at this point?
I think in the general area of risk communications, that we could always do better. I think even myself
what would
personally.
You do better? Like, what would you say to that person who is really confused right now and is listening to this testimony saying we're going way off label on dosing interval because we don't have adequate supply?
I would say that go to your trusted healthcare professional, because
who is that here? Is it you? Is it
no?
Nancy?
It's the family doctor, the person that actually would administer the vaccine, because
so now doctors.
The decision would be obviously with the programs in the provinces and territories that made the decision in terms at a population level.
You kind of get it. Kind of feels like it's
then
like
it comes
everybody
down to the individual healthcare professionals and
so now it's the doctors. So it's
point
like
of order, Mr. Chair. Point of order. If the member doesn't want to hear the answers, maybe she shouldn't ask the question.
No, I'm just very frustrated, Chair, and I think a lot of Canadians are as well. It feels like there's a lot of, and I get everybody's got a heavy job, but there's a lot of finger pointing here when I think some responsibility needs to be taken, and perhaps by the minister. Thank you.
Okay, thank you, Ms. Rempel Garner. So it's coming clear to me that we're not going to be able to finish this round before the votes.
Chair, do I have more time?
Can I make a point?
Seconds, please.
Can I make a point of? I think it's a point of clarification. Isn't that a procedural thing you can do? Because there's something the witness said, or am I totally wrong, Dr. Quach-Tan? I think it's really important.
Mr. Chair, he can't come in here as
Doctor.
He can't come in as a witness here.
Just steady down, everybody. Doctor, you'll have a time slot in the third round.
There's no such thing as point of clarification on the witness testimony.
It interrupts the
well, I think it's totally central to what we're talking about.
Mr. Chair,
Doctor, we can't allow it at this time. If one of your colleagues would like to share their time with you, that would be okay. But at this point, the speaking time for all the parties is well defined.
Mr. Chair, I'll share my time with Dr. Pulaski.
All right, Ms. Sidhu, you have 40 seconds left. Dr. Pulaski, you have 40 seconds.
Thank you, Ms. Sidhu, for that. So I think this is something really important, and I think probably most of the members in the committee didn't pick this up, and I would say a lot of the public may not appreciate the difference. When you, Ms. or Dr. Quach-Tan, you talked about the efficacy versus, I think, the efficiency, and the numbers are very different. Can you once again just clarify that so we understand what is the difference between those two terms and what is the efficacy versus the efficiency?
Absolutely. Thank you for that question. So efficacy means the vaccine impact in a randomized control trial where you actually choose the population that you include, choosing in the sense that you have very strict inclusion and exclusion criteria. Usually your population is healthier than when you use it in real world. Effectiveness is the impact of a vaccine when it's rolled out at the population level, which means that everybody is vaccinated. You have immunosuppressed patients, people with underlying medical conditions, malnourished people who might not respond as well to a vaccine. So you always expect effectiveness to be a little bit lower than efficacy because you have a much more varied population in whom the vaccine might not work as well as when you not cherry pick, but you select very strictly the participants in a study.
Mr. Davies' comments. Ms. Quach-Tan, did you have data that you were able to table with committee showing that any potential risks associated with the 4-month interval outweighed the benefits that you just stated, or vice versa? My apologies.
So there is a bulletin that was published last week from NASTI with the pros and cons of that recommendation. We will be having more data in that statement when the provinces have published their data. At this point in time, they were provided to us, but under confidentiality agreement, and we're waiting for those to be public to update that statement.
Would you have made that recommendation if there had been more supply of the Pfizer vaccine?
Of course not.
On January the 7th in Montreal, the Montreal Gazette, you said that the Pfizer and Moderna vaccines use a new technology. It can't be taken for granted that what has worked in the past will also work now. My gut feeling is that up to 6 weeks, I won't have any problems. After that, I can say up to 12 weeks, there are still problems. Still no problems? I'm not sure. Is the 4-month recommendation a gut feeling?
So it's based on the data that we have from the UK, from BC, and from Quebec, where up to 8 weeks, we see that actually the effectiveness is quite good. It's, as I said, we don't have data for up to 4 months in terms of effectiveness, but we have modeling data and we have expertise in immunology. And, it's really a decision that was very hard to take. But
you wouldn't be making that decision had there been supply of the mRNA vaccine.
If we had had enough vaccines to vaccinate all Canadians quickly, and at least those most at risk with 2 doses of vaccines, we would not have needed to extend the interval. That's for sure.
That's interesting. You started talking about the Pfizer vaccine being used, the 4-month interval. You characterized it as an off-label usage. Would that be a correct characterization?
Absolutely.
Do you know if I'll go to Health Canada, are there any contract implications for using the Pfizer vaccine for an off-label usage or recommending in this manner?
I'm not aware of any contract details. Those were dealt with Public Service and Procurement Canada.
And on that, I'd like to pause my time for a minute, Chair. Point of order. We did ask that Dr. Roman Sumsky, the Senior Vice President of the Vaccine Acquisition Branch, appear before the committee as part of this motion. Could you tell me why he's not here tonight?
All of the witnesses requested were invited, but they weren't all able to attend. I also will note that the bells are going, so we need unanimous consent to proceed. I suggest we might be able to squeeze in the rest of this round, but I'll ask the committee if they wish to do that. Is there any will to try to squeeze in the rest of this round before we suspend or adjourn for the bells, for the vote?
Sure.
I'm seeing general consent, so we'll carry on, and if it looks like we're running too close to the wire, we'll pull a plug then. So thank you all. We'll carry on. Ms. Rempel Garner, please.
Thank you, Chair. Dr. Quashtan, do you know how many doses of the Pfizer vaccines we would have needed in Q1 in order to avoid the recommendations that you made?
You would have to ask the Public Health Agency of Canada how many, and they have that data, it's just that I don't know them by heart, how many people fell into the highest risk categories.
Ms. Elmsley, would you table that with committee, preferably in a quicker pace than, or without having me to make me put a motion to compel it here, like let's say in the next week?
Yes, we will take that back to the department. Thank you.
Okay, and Ms. Elmsley, I will note that I might have to put forward motions to compel information from your committee that has that you've said you would provide that have not been provided yet, and I find that unacceptable. Dr. Berthome, have you had any interaction with with Pfizer or Health Canada with regard to the decision on the dosing interval between going from 3 weeks to 4 months? Have they advised you in any way on that?
I'm sorry, I'm not sure I understand the question. So the discussion between Health Canada and Pfizer were for the approval, and they continue about ongoing data safety issues, but the way the doses are administered in the provinces are not a matter that
Thank you.
is
and my last question with the time that I have left. Dr. Quashtan, did you consider, or did NACI consider the possibility of the development of vaccine-resistant variants, as a paper in the Lancet recently discussed, in your decision to recommend increasing the dosing interval to 4 months of the Pfizer vaccine.
We did, and the immunologists we consulted said that this was a theoretical risk, and they wouldn't see why extending the interval would increase the risk of having variants show up. The most important thing.
Can you publish that or table that data with this committee in the next week?
It was a discussion, but I can try and get you something in writing.
Thank you. Thanks, Chair.
Don't forget to like, dislike, subscribe, and comment. Safe Space Cafe. And always, have a good day.